Good morning, everyone. Thank you for coming so early in the morning for this conversation. I am Simbo Ige. It is now 4 months into my role as commissioner. It's been interesting. I have loved exploring Chicago and getting to know people. And today I'm going to be asking a lot of questions because I am just such a curious person. I have been around the world. I was born and raised in Nigeria, and I became curious about the rest of the world. And that curiosity has allowed me to participate in programs, interact with government, visit communities, and explore health solutions in over 40 different countries. That curiosity also brought me to the United States. I worked for many years with the United States Agency for International Development, and I was curious about how decisions were made. The United States is where decisions that impact hundreds of countries are made. And I was working in many of those countries, seeing how the decisions made in the United States impacted people in remote areas of the world who did not even know what the United States was or the people there. So I was curious about how these decisions were made. And that curiosity brought me to the United States. And while I have been here, I've also been curious about how decisions are made. What decisions were made that put the United States at the very bottom of health outcomes for peer countries? A country that's one of the richest in the world, and yet at the bottom of 36 countries that have comparable resources, or sometimes even less. I was curious about why healthcare access was not universal here. I was curious about how I'd worked in the global context, and the United States spends billions of dollars supporting human rights and improving health outcomes in many different countries, but not here. So if there's anything at all that describes me as curiosity, I'm always curious. Why are things the way they are? And why are decisions being made the way they are? I will tell you some stories. So in about 2000, a few years ago, I studied medicine in Nigeria, and in Nigeria, you have to do a year of youth service. That's what it's called. When you graduate from college, you are posted around the country to serve, mostly in rural areas, because that's how they get human resources to underserved areas. So it was mandatory. Everybody had to do the 1 year, and you get posted to different places. And I got posted to serve in a pediatric hospital in a rural area. It was about a 200-bed hospital. And in that hospital, I saw, this is a neglected tropical disease, so forgive me, I know many people will not even know what this is. It's guinea worm. So guinea worm is a parasitic infection that is transmitted when people wade into stagnant bodies of water, which often also serves as drinking water. So we spend a lot of energy treating guinea worm, and it's very debilitating, can lead to crippling and all of that. The worm gets into the leg, through the ankle, and it becomes a sore and it festers, and we treat and treat and treat. And then I became curious. I wanted to see where the sources of water were that was leading to this guinea worm. And in many of these communities, that's the only source of water. So I started to deliberate with my colleagues and like, instead of us spending all this energy treating guinea worm, wouldn't it be better if we could just provide an alternative source of water? And that's what we did. So about 4 of us went around, did concerts, raised money, and help create what is called, the pump kind of water source. And lo and behold, guinea worm started to go down and go down and go down until there was no guinea worm anymore. Guinea worm became extinct. That's one story. Another time, again, from the global context, thyroid disorders, goiter. It's a swelling in the neck that happens many areas of Africa where the water sources, again, lack of iodine is the primary cause. And so there are a lot of surgeries, and people come from the United States to do these thyroidectomies, and there are all kinds of, resources mobilized, and people will come for days and spend thousands of dollars coming to do surgery. And again, curiosity. Why spend all this time and energy on something like this? Isn't there a different solution? And in other parts of the countries and in other parts of the world, salt is iodized, right? And in these places, everybody uses salt. And so instead of mobilizing medical teams and surgery teams and coordinating the international trip and medical mission, we instead decided that iodized salt will be much cheaper, will be much easier to do. And so our campaign became iodized salt. And then what happened? Goiter started to go down and started to go down. That's another example. Now, coming back here, I had the opportunity to serve as an executive director of an international nonprofit out of Atlanta. A 200-year-old organization with hospitals in about 30 different countries. We had hundreds, over 300 mission hospitals around the world. And we had all these lessons that we had learned about how you can change population health outcomes. When you start going beyond the individual, I can stand in my consulting room and write prescriptions for you and you get better. But the question is, can I change the health of the entire population or the entire community by treating the individual one at a time? Or are there faster, more efficient, more sustainable ways of changing the health of population? So again, that curiosity, moving into this context. And Ron had mentioned something that we struggle with in Chicago now, the epidemic of violence. And so in Atlanta and in Georgia, it was the same problem. Kids were getting up to all kinds of mischief, fighting and stabbing each other and killing each other and all kinds of things. And there were all kinds of violence prevention initiatives and trainings and workshops and things and things and things. And everybody feeling very important. And we're doing violence intervention programs, blah, blah, blah. And then we started to think. Now, in places where there's Boy Scouts or Girl Scout or sports or activities, kids tend to behave better. Why? Because they're busy. So why don't we keep the kids busy instead of trying to fix them with workshops that they promptly forget once they're out the door? So we started to invest in after-school programs. Sport, music, art, whatever, just keep them busy doing stuff. And we started to keep the kids busy doing stuff. And the busier they were, the less likely they were to be, subject to predatory activities by people who were up to no good. And the less we had to work to change their behavior. And then what did we see? Stabbings, fightings started to go down and to go down and to go down. My point is, we put a lot of emphasis on fixing problems, fixing individuals, and we forget the very origin of public health. How many people know the story of Jon Snow? Okay, so I'm going to tell it anyway because not everybody raised their hand. So Jon Snow, this is a story of cholera in the UK, in England, back in the day. And very similar to all of these stories, there was cholera everywhere, cholera outbreak. Nobody knew what cholera was then. Nobody knew what the microorganism was. They just knew people were stooling and vomiting, and it wasn't good. And tried as they could, all kinds of remedies, it just kept happening. And then they started the curiosity, and they started to trace and trace and trace, and they realized it was from a particular pump. If you get your water from this pump, you get sick. Nobody knew what the disease agent was. They just knew there was an association between getting your water from this source and getting sick. Simple solution, remove the pump. Duh. So pump removed, cholera stopped, problem fixed. And that was the birth of public health. That when we start to look at things at the population level, and when we start to interrogate and be curious about the factors in the environment that influence our health, we could potentially go faster and have more sustainable solutions to some of the challenges that we're facing. So why is it that 200 years after that amazing discovery that if you remove the pump, you can stop the disease, we're still here? Why is it that these issues have not resonated and stuck? And that is the curiosity that I carry now as a commissioner. There are many, many, many challenges that we're facing in the city of Chicago. And many times our approach to the problem, even in the world of public health, we are now wading, we continue to wade and wade and wade into the water, where we think that by treating disease and doing crisis management, we will somehow go from the individual to the population. And we forget that all of the research in social determinants of health, all of the things that we've learned from all of these different examples require that we focus more on those social, environmental opportunities to make change happen. So in the city of Chicago right now, we're a city of 3.7 million people. 1 out of 2.7 million people, I beg your pardon. 1 out of every 4 Chicagoans has a mental health issue. It didn't start during COVID. It started long before. And the trajectory has been this way: a steady climb, and a steady climb, and a steady climb. And we have been working very hard to increase the number of mental health practitioners and training more people to treat the problem. But the disease outpaces the supply of practitioners. And there's not enough to go around, and the disease continues to climb. And I challenge my colleagues sometimes. I was like, are we missing something? Are we missing something? Is it time for us to begin to go upstream? What is it that is driving this epidemic? And it was not just COVID. It started long before COVID. And are there things that we need to change in our environment and in our society to lead to a more sustainable change in outcome. So as researchers and as academics and population health enthusiasts, that is the question that is ahead of us. And that's one of the things that we're working on now in the city of Chicago. We also know that in the city of Chicago right now, if you are a Black person in the city of Chicago, you are likely to live a shorter, tougher life, period. Regardless of the health outcome, you are likely to suffer from it more often than other people who are not like you. And so the solutions that we have to that is, let's do more workshops. Yeah, we like workshops, trainings, right? Let's train. Let's tell people, you should eat well, you should do this, and you should do that. And we should tell people how important it is to come for their appointments. And we should tell people all the different reasons why the things they're doing are not appropriate. Except that we forget, though, if we make these appointments, if you live in the Black communities, you have to travel longer to come for those appointments. You are likely to work in a job where you don't get time off or sick leave. And you will likely not have childcare or be able to pay for it. And so people don't come for the appointment and they don't show up for the appointment. And we huff and puff and huff and puff and say the health outcomes are bad because people are just not doing the right things, right? So we continue to see the disparities continue to disparity. And we invest billions of dollars. My last job here was from the Robert Wood Johnson Foundation, the biggest philanthropic organization in the United States. Billions, over $3 billion spent on health equity today. And the disparities continue to widen and to widen and to widen and to widen. So in the city of Chicago right now, there are gaps as much as 17 years between communities. And so my question is, what is in this community that is not in this community? If I replicate what is in this community, will I get the same outcome? Or do I expect that I will continue to train people in this community without the things that are in that community and somehow magically get the same outcome in that community? Not likely. Not likely. So that is the second issue we're dealing with. How do we close the gaps in health outcomes? And I can tell you how we do not do it. It is not by training. It is not by workshops. That we know. So that is our second priority. Now, chronic diseases. When we had COVID, public health emergencies, we rally, we invest billions of dollars. Everybody's panicked, everybody's running around because it impacts all of us, right? When we have outbreaks of infectious diseases, it's not always good, but we do very well with infectious disease response. What we don't do well is chronic disease. And yet, when we break down life expectancy in the city of Chicago, chronic disease is the biggest contributor to life expectancy gaps. There's no media. There is no national, state, local, city, nonprofit partnership. No. It's invisible. We don't put our resources, we don't put all of our energies the same way we do when there is an epidemic of and infectious disease. And yet, this is the biggest threat that we're facing. Epidemics of chronic diseases. And so that is another thing. How do we create the same kind of energy and momentum and attention and collaboration and partnership that is required to solve outbreaks of chronic disease, outbreaks of infectious diseases for chronic diseases? So that is the third thing that is ahead of us. So as the commissioner for the city of Chicago, in addition to our foundational responsibilities, these are also issues that we are wrestling with. The epidemic of mental illness, the intractable, deep-seated, long-standing health inequities in the city of Chicago in all different dimensions, chronic diseases, so these are all things that require extensive collaboration, but also things that require social change and social movement. So when I say social change, I reflect on examples like how, and we continue to struggle with some of those things, but how social change has driven a lot of policy and infrastructure change in the United States. And so I reflect on examples of how the Environmental Protection Agency was developed as a result of a social movement. People making noise, people making a lot of noise, people continuing to make a lot of noise until it could not be ignored and somebody did something. We have seen social change movements for more inclusion and diversity, social movement around gender and LGBTQ, access and services and what was 10 years ago. And now we're not there yet, but there has been some movement, again, because people made a lot of noise and continue to make a lot of noise and continue to make a lot of noise. And when we saw movement like the Me Too movement, it was collective action that was based on individual action. Somebody started to make noise and other people joined the noise and more people joined the noise and it became a lot of noise that could not be ignored. So how do we start to make noise about these issues? We need a social movement. We need a lot of people making noise. We need the noise to be persistent. And we need the noise to be a lot of noise for change to happen. And social change is slow, but it requires a lot of noise. Now, as long as the noise, now when we talk about health inequities, if I make noise about inequities, I'll say, oh, she's a Black woman. Yeah, they complain all the time. They whine. But if I'm making noise and you're making noise and you are making noise and everybody's making noise, then it is not just their problem. It is our problem. As long as these noises are limited to certain groups, we don't get to population change. It cannot be the issue of one group. It has to be the issue of all of us. That's how we solved COVID. If we're going to solve mental health, we have everybody has to make noise. It cannot be those people or their problem. It has to be a shared goal and all of us making noise. And why do we need all of us making noise? So imagine If you walk into your office and you walk in a communal office with many, many different people, and in that office, you are the only one with internet. Everybody else does not have internet. And you come in every day and say, oh, I can do all of this amazing work, and nobody else can get their work done. How happy are you going to be? Not very happy. Everybody's going to hate you. And you will not be able to enjoy that internet. So if you go into, I have two boys and I see them vying sometimes. So one is a better cook than the other. So the one who's not such a good cook, he makes himself a sandwich, 2 slices of bread, put the peanut butter and jam in it, and that's it, he's going. And then his brother comes along and he starts to lay the table and put the napkins and starts to chop and dice and put all kinds of things in there. And all of a sudden, his peanut butter, and he's like, what are you doing? Can I have some? Like, no. And it's like, you made your sandwich. It's like, I made my sandwich. But he's never going to eat that sandwich in peace. He's going to chase him. He's going to grab it. He's going to, that's like, but you made your sandwich that way. There cannot be peace if there is no equity. Whether you made your sandwich that way or someone else made that sandwich that way, as long as I can see that sandwich and that sandwich is better than mine, my God, you are not going to have any peace eating that sandwich. So we have to make collective noise about these issues. And it cannot just be, that's how you laid your bed and that's how you're going to lie on it. Because you are not going to sleep in peace on that bed, I'm telling you. So this is an imperative for us all to address these issues. And the final reason why I think is an imperative is Chicago, again, is a city of millions. We have one of the most diverse economies in the world, this city. This is one of the top 5 destinations for new graduates in the United States. When I say diverse economy, our economy is not just based on one thing. We have healthcare, we have industry, we have manufacturing, we have all kinds of things. So the mayor likes to say this is one of the greatest cities in the world, and I'm beginning to see why. But one of the other things that's unique to Chicago is this is a city that welcomes 50 million people every year for tourism. So we are not just solving for the problem of 2.7 million people. We're also a city that welcomes hundreds and hundreds of people, millions and millions of people every year who come from different places here. What will it be like if every citizen, every resident of Chicago was functioning at their peak, could maximize their potential? This could truly be the greatest city in the world. This is a city where we have an almost even mix of races and ethnicities. We have about 33% white folks, about 28% Latino, 29%, 30% Latino, 30% Black folks. But the Latino and Black are operating at like half of their potential. If everybody was operating at the top of their potential, what could Chicago be? What could Chicago be? Would we be the city that keeps bringing all the medical experts to come do thyroidectomy? Or could we be the city that says, you know what, let's just put iodized salt and make life easy for everybody, and then we don't have to spend our energy and resources on some of these issues? And that is my hope, and that's my vision, that I can help build a social movement and a collective commitment to addressing these health issues that keeps holding us back, where we're spending tons of our resources on crisis management instead of going upstream. So our work in the Chicago Department of Public Health is prevent, promote, and protect. Prevent, promote, and protect. Prevent from the threats, promote the best practices that help to keep people in good health, and protect our environment, social conditions, food, and all of the things that are necessary for healthcare. So I look forward to further conversation. I'll tell you a little bit more about myself in a minute. But I hope that I can count on you all as we continue to wrestle with some of these 21st century challenges in health for the city of Chicago, and that together we can make a difference in some of those very, very wicked problems and complex problems we're tackling in public health. Thank you, everyone, and good morning.
Wonderful. We have a seat over here. So I think the room is filled with 200 plus very curious people. So it was excited to hear about the arc of your career and how curiosity drew you from initially what sounded like clinical training and realizing this won't be enough. Isn't there better ways to address these health issues? And what sort of call to action would you give us we have students, we have faculty, we have staff, we have clinical professionals and community folks, and many who've worked in public health, all curious, all, I think, ready and willing to contribute to that call to action and that voice that you just described that we all need to be part of. What message would you give to us all that we can do right now to contribute to that resounding message?
Thank you, Ron. Every time you interact with an individual, beyond the very present issue, the curiosity, every individual is nested in a family, and that family is nested in a community. We all are very familiar with the socio-ecological model. Many times our practices and the time that we have does not allow us the opportunity to dig a little below the surface. So it's a conveyor belt kind of environment that we have, and things are moving rapidly. But my encouragement to everyone is that family and social history should just take a little, pique your interest a little, because every individual is a product of those issues. Even individuals' ability to adhere to medical guidance and instructions is influenced by their family and their community. We're not likely to make the kind of progress that we want without an understanding of where is this person coming from and what is their story. So every time you have a little opportunity to just ask a little more about the context, I think it always serves us well. The curiosity that I have experienced was in trying to understand the context of the patients that I was seeing. And as I asked more questions, where do you live? Who do you live with? What work do you do? You start to see some patterns emerge that you start to wonder about, like, is there something going on beyond what I'm seeing here? And so that will be my encouragement to everyone. Be a little more curious. We do a lot of investigations, blood work, and all of that to get to the root of the problem. But we know now there's a lot of data, and we know that what we're seeing is, it's not just the product of the disease agent, it is a product of an interaction of many different complex factors. And so if we want to accelerate progress and we want to improve health outcomes, even for the individual, there is a need to understand the individual a little better, especially the context. And as I've come to Chicago, is the same approach I have used. This is an interesting city, but there are layers and layers. And if I come to the city with, oh, I have worked in New York and I have worked in Atlanta and I've worked in many countries in the world, and therefore I know what to do and blah, 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 without trying to stop and reflect on what is the context here and how can the context inform how I approach the problem and the issues. I think that's always something to just hold. Do you know the full story?
You also talked a lot about, you talked about how your curiosity drew you upstream thinking, and naturally that pulls one into public health. And that public health curiosity has taken you from Nigeria to the UK. You talked about Atlanta, New Jersey, New York. Why the commissioner of the Chicago Department of Public Health? What most attracted you to that position?
There are three things that made this so irresistible to me. um, and I laugh because it was one of the toughest decisions I had to make. I was working at Robert Wood Johnson Foundation. It was posh. It was easy. I had work-life balance. I could switch off and say, this is my work day. And then choosing a job where there is no work-life balance, I don't even know what that is. It's nonstop. You're a public servant. Everybody expects you to be there at the push of a button. And so I came into this with my eyes wide open, knowing how hard and how challenging and how difficult it's going to be. And I did it for three reasons. One, the Chicago Department of Public Health has been around for almost 200 years. And at no point in those 200 years had a Black woman been found worthy of leading that department. So the opportunity to be the first person in that role, an immigrant woman, Black woman, to be considered for that role, I thought was a unique opportunity. And I felt, yeah, I think I have some experiences that may be useful here. And I felt it will just change the dynamic, will changing the lens and the perspective and the experience influence somehow how we do things. So that was one factor. The second factor is having been in New York and seeing the role that politics play in health outcomes. I understand that public health is not just the science. It's not just all the research and all the statistical significant differences. It's about how can we take all of the best practices and operationalize it in a complex political environment. And, and there are very few more complex political environments than Chicago. It is a very complex political environment, but how can public health thrive in the midst of such intense politics? If we don't figure it out, we're not going to make a lot of progress. So there was that curiosity, like a new administration, a progressive administration, complex politics. Let's see if we can mix public health in there in a way that lands with political leaders, and if I can spin it. So again, that curiosity. And then the third thing that piqued my interest is that the Chicago Department of Health had been working on this life expectancy thing for a while. Many times in medicine and public health, we're very specialized. Our work is compartmentalized, is COVID or tuberculosis or HIV, and no, so it's whack-a-mole. We try and squash this and then something else pops up. We squash this and something else pops up. And there were a few departments of health that wanted to do it different and say, okay, what if we can tackle it all at the same time a very lofty goal. We don't know if it's going to work or not, but I thought it was worthwhile. I mean, I would like to be a part of that conversation. Let's see what we can do. So all back to the curiosity. You know, I like, try new things, tough things. And I also thought that it was important that when it comes to the health equity conversation, that this is not just about people of color saying to other people, do stuff. Nobody likes to be told what to do. So what if we roll up our sleeves and get into the game and try and do the best that we can in this context? So those were some of the reasons why I said, let's do Chicago. Let's see if all of these theories in my head, swirling around in my head, all of these experiences I've gathered over the years will play out in Chicago. And so far, so good. I'm loving it so far. Yeah.
So as the agency continues to address the current problem, and there's many of them, and you're doing whack-a-mole, you know, many of us in the audience are familiar with strategic thinking at the agency and the prior renditions of Healthy Chicago and sort of broad strategic roadmaps to the work of the department. How do you think in the next, you talked about strategic priorities in your opening remarks. How will what will look different at the health department in the next year in terms of action or strategy? Is it is it strategic thinking first? Are there particular initiatives that we should expect to see moving forward in the next 6 to 12 months?
Yes. So a few things that we're beginning to rethink how we do. I already described it, you know, some of the different ways of looking at problems, from crisis management to crisis prevention, from individual efforts to population-wide community level efforts, looking for policy solutions, mostly rather than individual solutions. So those are some of the things that we are, the executive team, beginning to bring into our work. But there are a few examples also where we're trying to be a bit more tailored and precise in our work. One example is we're looking at life expectancy, and we're looking at the major drivers of life expectancy and drilling down to see, we have seen a surge in opioid overdoses. And when we begin to map that and look at the heat maps, we see more EMS responses, yet more people dying in some communities over others. So the same opioid crisis, the same overdose, the same EMS response, but this person dies and this person doesn't. Why? And when we look at our Narcan distribution and saturation maps, is the dose and intensity, is it proportional to the size of the problem? So we do a little here, a little there, a little here, a little there, but dose and intensity also matter. In other examples, so looking at how deep we are invested in certain communities is in a different lens to the work. Another example is violence prevention. We've been in the street outreach violence prevention space for many, many years. But in some communities, like the gang activities, they're like maybe 100 or something different gangs. We have 5 outreach staff. So, you know, you do 1, you engage 2. If you engage 3 out of 300, what change would you actually see? You need to engage, you need to like 50 people in one community doing 4 days or 5 days of intensive work for you to begin to see a change. So we need a 75% coverage for things to begin to move, and it's going to take a couple of years to move. So when we start projecting the trajectory of life expectancy, the intensity of the effort and the duration of the effort matters. So we started to bring in lessons from tobacco. With tobacco, we had resettlement funding. It's been 20 years to get to a 97% reduction. But this was a reduction that was, it didn't vary much by by race and ethnicity. So that's one success story. So we got consistent reduction over time, and this reduction was consistent across race and ethnicities. So what did we get right there that we can apply into other spaces? So beginning to look at our actions and how precise we are being in our investment and in our focus is one of the areas where we're thinking about differently, and what complementary activities are also necessary. So how intense, how deep we are in our interventions, but also public health is never due to one factor. It is always multi-factorial problems, complex problems, and therefore it is impossible to fix a complex problem with a simple solution. So saying, oh, I do street outreach or this, and then violence is solved is ridiculous. It has to be a complement, layers, like in winter, you just layer the clothing. So it has to be layers of investments. It's not like I put 20,000 here and then someone says, where's the impact? Impact of what? Yeah, like we need layers and layers and layers of interventions to solve the problem. So going beyond simple solutions for complex problems to collective action models where we are pulling in resources and layering programs in many different dimensions. Again, looking at the example of HIV was not just the educational component or behavioral modification. It was innovation in the treatment, addressing some of the stigma issues, housing, increasing access, looking at all of who the messengers are and all of that combined to have brought us to the lowest incidence of HIV we have seen in 40 years. So we are paying attention to what has worked and what has worked equitably to then begin to model what we should do different going forward. So those are some of the ways that we are beginning to think about the challenges ahead of us, how deep, how many layers, and how long it takes, so that we are making accurate projections of what is going to be needed to make change happen.
And you've had this very deep, rich experience for the last 15 to 20 years in public and population health. You described the activities in Atlanta and New York and elsewhere. And I wonder, are there things that worked there, ideas that seem to get traction and have impact that you want to bring to Chicago?
Yes, there are a few areas that we're exploring now. So in New York, I was pulled into the COVID response because of my interest in health equity and because of my absolute unshakable belief that inequities can be reversed. So New York was the epicenter of the pandemic, almost 9 million people, 800 languages, all kinds of inequities at all levels. And so when the vaccines started, I was asked to lead that work with the equity lens. And it was a very humbling experience because typically we say, oh, bring all the professionals, bring all the doctors, tell people I am the doctor of the city, I am the PhD and I'm the MD and MS and all the things that we like to say, and nobody gave a hoot. People went to their neighbors and said, okay, so this thing, someone says to their neighbor, drink bleach, and they drink bleach. And somebody goes to their grandmother or their church sister or somebody, and they say, you know what, onions. That's the solution. Just eat onions, and people are chomping on onions. And it was fascinating how much people believed what they heard from random people. So we started to pivot. And our focus then in New York, New York public housing residents, almost 600,000 people. It was a city in itself. They were devastated by the pandemic. We lost so many people, and we began to wonder, how are we going to get vaccine uptake? at NYCHA. And so our approach there was use NYCHA residents to talk to NYCHA residents. It didn't start that way. Everybody said, bring the van, put the logo on the van and say, the Department of Health, we are here to save your life. Come out and get a shot. Nobody came out. Nobody came out. Maybe 3 people or 4 people who were very curious and like, what are you doing? Nobody came out. So everybody was at a loss and said, let's use the NYCHA residents. I was like, but they're not medical people. And like, they don't need to be medical people. Nobody's taking the vaccine because of all the ingredients that was in it or because you convinced them on the 3 levels of trials and all of that things. All the things we're putting in the PowerPoint and all the webinars, nobody was interested. And so our job was to convince those who are taking the vaccines to talk about their experiences to others, to wear a t-shirt that says, I got the vaccine, ask me about my experience. Now, these were neighbors that they knew. These were people that lived in the same community, had the same experience. Like, this is my vaccination card. I got the vaccine. I think you should get it too. And when we started, vaccination coverage in NYCHA was at 39%. The rest of the city was at 65%. And when we started to use NYCHA residents for education, everybody at CDPH knows me now. I said, I like to see things that were down going up, and I like to see things that were up going down. And then things started to go up and the numbers started to climb and the numbers started to climb. And in 3 months, vaccination coverage at NYCHA had reached 98%. It had caught up and exceeded the rest of the city. And the lesson there is put the message in the mouth of trusted messengers. And that's, I said, very humbling because we went to school and spent all these years in college and learned all the big scientific words and all of that. And now what people want to listen to is like Miss Jane from next door. I was like, well, Miss Jane from next door is getting the job done. So we had better put the message in the mouth of Miss Jane. And that's what we did. And so I'm hoping that we will become a bit more comfortable in letting others into the work. And so now I say, let's put the public back in public health. Let's not be threatened by the fact that others can probably deliver the message better than we can. It doesn't have to be complex messaging because things just have changed. And so can we use that same approach for other things to help people open up to the message that we are trying to land? So that's one example of how do we communicate differently in 2024. So that's one lesson. The other lesson is how do we do more prevention? And I've talked at length about that, so I will not talk about that a lot. There is a lot of interest in healthcare, which is good because we have intense disparities in healthcare, but not as much interest in public health, prevent, promote, and protect. And so we spend all the energy putting out the fires and trying to get people into treatment and not as much energy upstream. So that's also another lens that I'm hoping to bring to this work and some of the lessons we have learned in other places. I also believe very strongly in partnership and collaboration. Nothing gets solved because one organization decided to solve it. Things get solved by everybody coming together. And that's why I appreciate, this opportunity to be here. And there are many, many other passionate, like-minded people here who, if we, with our collective voice and a social movement and start to uplift, like these are important issues. Chronic disease are important, inequities are important, and we begin to make noise and make noise and make noise, we will get some traction. And in many places where we have led those kind of collaborative partnerships and cooperative spaces, we have done a lot more. So one example of how we're doing that now is we have a measles outbreak. it's impacted those who are mostly unvaccinated, which means the new arrivals to our city have been disproportionately impacted. And we had an experience where we had 900 people exposed to measles in one day. It's like a time bomb. Measles is so contagious, 90% of those who are exposed, if they're not vaccinated, are going to contract measles. And boom, that happened. One case in a shelter with 2,400 people, 900 people with no vaccination history. We could have landed with 800 measles cases within 3 weeks. That would have been a disaster. And we had to mobilize within 24 hours. Now there is no funding for measles. We have 1/3 of the staff that we had during COVID. I have 32 public health nurses total in my department. And it was not just about, hey, stand here and let me put a jab in your arm. It was intensive one-on-one education trying to convince people. So I went to the alderman and said, Alder, we have a problem. We need your help. And we need all the Spanish speakers who are trusted voices in this community to come join me in talking at the shelter. And they came. And then we said, do we have priests here who have a relationship with the community? And they said, yes, we do have priests. Let's bring the priest. And then do we have the representatives from the consulate who we know are here as advocates? Let's bring them. And do we have people who have worked with the community and the community health workers and speak the language? And they said yes, and said, let's bring them. And then we started to knock on the doors of all of our healthcare partners. And you said, do you have vaccinators to spare? We need your help. And they came. And we knocked on the door of our county partners and said, county, we have a problem. We need your help. What can you do? Said, oh, we can help do symptom monitoring and all of that. And they came. And we said, hey, state, we need help. And the state said, you know what, we can give you HEPA filters and we can give you vaccines. And they started to mobilize vaccines. And then we knocked on the door and say, CDC, we need money. Said, we don't have money. What else do you have? We have staff. Okay, bring the staff. And they brought staff and they deployed their P8. And we began to cobble together all the assets and the resources that we had. And that's how we've played it. I go sit in my office and whine and stomp and say, why didn't somebody give me 80 million? I need 20 million. And said, I cannot do the work because I don't have 80 million. But public health is about the public. We, in an emergency, people always rally. So we bring all those people to. So I believe a lot in collaboration and partnership. And there is something special, Americans, when the chips are down, there is social solidarity. People will pitch in and people will help. And that's been the case. And people will pitch in and people will help and we turn the curve. And so all the other problems, I hope we can all pitch in, roll up our sleeves and say, yes, let's do it. So those are some of the lessons that I've learned in my work, working with what we've got, mobilizing asset, putting the public in the work and getting, moving things along best as we can.
Well, this has been wonderful. I mean, we've come to the end of our session. There were a few more questions, but you really, I think, inspired pretty much everybody here, to be part of your vision. I think some of us are ready to walk out the door and follow you back to the department. I think as the session concludes and the day goes by and the days ahead sort of unfold, we'll be looking for opportunities to contribute. Many of us work in areas of community health and social epidemiology and social change, and we just don't always know how to, get that knowledge and the resources into action at a public level in the way that you're describing. And we want to help. We want to be part of the voice. We want to contribute to the solutions, and we hope we can follow up with you and your agency and help you on your way and really make Chicago. I like that you came from New York and you're describing Chicago as the first city as opposed to the second city or the fifth city. So thank you so much, Dr. Ige, for sharing your time with us this morning.
Thank you. Thank you so much.